আজকের টপিক ছিল ইভ্যালুয়েশন। তোমরা সবাই এই সম্বন্ধে তোমাদের অনেক ধারণা আছে, কারণ এমডি ফেজ এ ফেজ বি সব জায়গায় চেস পেইনটা খুব ইম্পর্টেন্ট। তারপরেও পরীক্ষা এটা টপিকস ফর দ্য রিটেন or viva everywhere is most important topic. I'm starting my this class. I don't know why I cannot hear you. Do you hear me? I don't know, but if someone chat box, do you hear me?
Yes, we can hear you.
We know chest pain is the chief complaint in the emergency department, but outpatient department it about 1 to 2% of the outpatient visit. Most of the cause is non-cardiac, but heart disease is even the leading cause of death. Chest pain in the emergency department more than 50% due to cardiovascular condition. In outpatient, primarily musculoskeletal condition, GI disease, stable coronary disease, pulmonary disease, sometimes anxiety neurosis. But in almost 50% never reach a definitive diagnosis. So we should meticulously take the history, also some examination and available resource, that is investigation. You see, in case of primary care in the United States, musculoskeletal condition is 36% in the OPD, but in the CVD, which is cardiovascular disease, is 54% in the emergency department. So we should, in case of emergency condition, we should first kept in mind in the cardiovascular disease. The clinician mode should be focused on the immediate recognition and exclusion of the life-threatening cause of chest pain. One patient comes to the OPD or emergency. If he chest pain in the emergency life-threatening condition, we should meticulously examination is within 10 minutes time, because in 10 minutes required to damage the myocardium, also some pulmonary embolism, pneumothorax. So if you consider any life-threatening condition, you should immediate diagnosis. But if it is not life-threatening, you should take time in the OPD, then you do the investigations, send the patient in the some investigations, and send patient the home and coming again to your OPD. Then you can have time, because only 2 to 3% cases in OPD in the chest pain, the cardiovascular disease. We know everybody cardiac cause is the ischemic cause, that is coronary disease. Non-ischemic is the aortic dissection, pericarditis, aortic stenosis, hepatic osteocardiomyopathy, and mitral prolapse. And non-cardiac is the pulmonary embolism, pleurisy, pneumothorax, esophagitis, costochondritis, myositis, and in case of neuralgia, we know the heart register is the neuralgic pain, severe chest pain. So history is the key to the diagnosis of the etiology of chest pain. History I always history is the most important. So in the long case, also in the short case, in the written, you always emphasize on history. Duration, OPQRST, OP1 constant duration, D propagative factor and palliative factor, Q is the quality, R radiation, and also severity is should be focused. With some pain assessing scale, this visual analog scale, that is numeric pain intensity scale, simple descriptive scale, graphic scale, verbal reading scale, pain faces scale, numeric pain intensity and pain distress scale, memorial pain is lots of clumsy, but I discuss later on one pain assessment scale. We should search for the accompanying symptom, that is shortness of breath, diaphoresis, excessive anxiety, sense of dooming, nausea, lightheadedness, dizziness, neurological symptoms. You should search for some symptoms with the chest pain. You should examine the patient thoroughly, that is vital sign. Blood pressure in the both arms should be both arms, peripheral rub, murmur, rub also, chest wall tenderness, epistic tenderness, and some rash. So you should examine the ribs and muscle, there is inflammation, costochondritis, some lungs, respiratory system is pneumonia, also angina, myocardium, so cardiac, some gallbladder pain also refer to the chest, so polycystic gallbladder, cholecystitis, also reflux, so whether it is so abdominal, cardiac, respiratory, musculoskeletal, also some neurophysical disorders should search for the chest pain. We know causes of chest pain: gastrointestinal 42%, ischemic heart disease 34%, testicular syndrome, pericarditis, pleurisy, also pulmonary embolism, lung cancer, aortic aneurysm, aortic stenosis, and also hyperzoster shows some cause of chest pain. Lots of thing is written in the book. You should read this thing. You always already you know, but you should memorize in your mind during examination what history should taken by you, also approach of the patient for diagnosis, because if you don't know the causes of, you can approach the diagnosis. Also, most important is the patient age of the patients, male gender, female gender, and the duration of the pain. Also, you should keep in mind. Classification of chest pain: typical angina, that is gastrointestinal, tension to the left arm and jaw, provoked by exertion, relieved by rest or nitroglycerin. Atypical fulfill only some criteria. Non-anginal do not fulfill any above criteria. So typical angina is usually not found in the chest pain in case of angina pectoris. Only in the unstable angina infarction. That is you find in the emergency department, but in the patient is not come to the not so much typical angina, but patient usually give the pain of angina pectoris is provoked by the patient and relieved by the stress. It is the most important. Patient should tell you when chest pain is increased by patient and relieved by rest, and sometimes taken by the NTG. So you should search the chest pain character also. So trials of chest pain. In the evaluation, you should carefully taking physical examination, recording and evaluation of the 12 ECG within 10 minutes of arrival, measurement of biomarkers, not to miss the cause of chest pain. Always you should search everything, that is pulmonary embolism, aortic dissection. It is the grave cause of the aortic tension pneumothorax, also from grave cause. So you should take the at least history on state, side of the pain, character, duration, accompanying factor, relieving factor, local tenderness, and some symptom severity. Research of the 10 points meticulously to approach the patient chest pain diagnosis for the it is either cardiac or respiratory or abdominal, that is cholecystitis, or sometimes anxiety disorder. You should assess the chest pain. That is zero, that means no pain, and sometimes 1 to 2 is a mild pain. That is, patient can be ignored this pain, and there is maybe scale is gradually increasing. It is moderate pain. 3, 4 is the interference with the task or sleep. Moderate pain when some disturb in the concentration, that is 5, 6, and some severe pain, that is can do the normal activities hampered. It is the 8, and most pain, that is bed rest required, severe pain. So this scale can be you can the OPD, but we cannot follow this thing because it is the usually I think it is the theoretical part. One thing, no pain. Pain is the impaired physical activity, some ordinary activities, clothing and something, and patient is the severe pain, and sometimes it is the taking the bed rest. The 4 criteria can be even that universal pain. You should evaluate the pain. Could the chest discomfort lead to acute life-threatening condition, severe immediate hospitalization, and we should evaluation, acute ischemic heart disease, aortic dissection, pulmonary embolism, spontaneous pneumothorax. This is the most grave disease. So you should immediately diagnose the acute MI, aortic dissection, pulmonary embolism, spontaneous pneumothorax. But some is chronic condition, that is testicular angina, aortic stenosis, pulmonary hypertension. If not, could the discomfort lead to acute condition that warrants specific treatment, pericarditis, pneumonia, herpes zoster. If not, then is good some treatable condition, that is reflux, severities, spasm, peptic ulcer disease, other GI conditions, cervical disc prolapse, disc disease, arthritis of shoulder joint, costochondritis, and some anxiety stress. So you should evaluate gradually according to the severity of the patient. This is the that depends on the ischemic chest pain and non-ischemic chest pain. It is the sometimes you can location of the chest pain, that is central chest pain, relation to the jaw, neck, shoulder, arm, tight, squeezing and choking pain character, and visible by the exertion and relief by the rest. Also some shortness of breath, the ischemic chest pain. But peripheral pain, localized 1 point localized pain, no radiation, sharp stabbing pain, catching pain, it is spontaneously relieved by the posture changes or respiration or palpitation or relief, not relieved by the rest. It is sometimes respiratory problem, GI problem, and psychological problem with the non-ischemic chest pain. So you should approach this way. There is some heart score in the approach in the department, history, highly suspicious 2, moderate suspicious 1, 0, non-suspicious 0, and ECG statistical depression is the 2, and some non-ischemic is 1, normal 0. Age more than 65 years 2, and 1 more than 45 to 65 0. Risk factor more than 3 factor is the atherosclerosis disease, and 1 is 1 or 2, and no risk 0. Troponin raised is a 2, and is within the normal limit or upper limit is 1, 0, low risk. So heart score less than 3 should be less than 3. If it is more than 3, 3 that is 4 to 6, and 6 more than 7. It is more than 6 weeks. It can be followed in case of theoretical purpose also, but you should keep in mind there is a rapid identification of the MI or other diseases. And everybody, angina pectoris, typical distribution of the axonal pain, correct rest and exercise or cold weather by the rest. I discussed you severe pain in the chest, it is acute MI, like is in the elephant on the chest. The Levine sign is the typical sign of chest pain. Is the thumb in the chest bone, the Levine sign, and point sign is that is discarded the chest and the cardiac causes. And some referred pain, the shoulder, jaw, and the arm and limb also. Some is the little finger also. Everybody something back and this front also. The localization pain. You see the localization of the pain in the both jaw also. So you should do the ischemic cascade in the examination. How ischemic cascade is going on? Should know this. When in the hypoperfusion first, then metabolic disturbance, then ischemic dysfunction, then dysfunction is chest pain, and then is myocardial. So chest pain is coming. The when is the later stages. So you should diagnose the chest pain and immediately start the necrosis. Is the most important time is chest pain, because chest pain is the 6th stage of chest in the ischemic cascade. In the before the myocardial necrosis, patient pain the chest pain. So you should diagnose chest pain immediately. So you see, in case of the perfusion, there is nuclear imaging MRI is the first diagnosis of the hypoperfusion. Then echocardiography is the diastolic dysfunction and systolic dysfunction. Then you go to the ECG, then angina, then you have necrosis. So you should know the ischemic cascade. Rationally, you should circumstances. So cardiovascular, is coronary disease, vestibular angina, non-STMI, STMI, and we know the angina is the sometimes there is a chest pain. Angina more than 10 minutes, non-STMI more than 10 minutes, STMI is more than elevation. Everybody, cardiac angina in the STMI, non-STMI. So in the biomarkers also, the onset 3 to 2 hours, troponin persists up to 10 days, CKMB is 36 to 40 hours. So the repeat test is the early. ECG also localizes ECG to estimation is the diagnosis in the STMI, but sometimes the old age and diabetes. So sometimes old age patient diabetes cannot give the typical presentation. So you talk with the patient any time of any confusion, you do the serial ECG, also troponin I should admit the patient in the hospital. Everybody treatment recommends the morphine, oxygen, nitrates, heparin, PCR, CBD, receptor modification, also. And second is the most important dissection, which always sometimes without decision in the CCO. It is the most not rare form of disease. Severe tearing and stabbing pain, sudden onset, and related into the back also. Depend, what diagnosis of the aortic dissection, patient is hypertensive. Sometimes the pulse is asymptotic pulse in the both arm and aortic dissection. When is aortic dissection is coming with the hypotension, there is a great condition, severe tearing of the aortic and with the hypotension. So immediately go to the ventilator or something, the intensive vein. So factor, hypertension, coarctation aorta, trauma, and it is uncommon cocaine. And clinical finding, everybody. There are two types, type A and type B. Type A is when involved the ascending aorta, it is type A. It is standard classification, and type B involved the descending aorta. Chest ratio, more than 8 millimeter dilation, and CT-MRI is the most correct diagnosis of the aortic dissection. Is clearly delineated the dissection, but echocardiography can diagnose that, but it should do the CT-MRI to diagnose the type A, type B extension of the dissection. And it can be high sensitivity and specific transvascular, and aortic angiography can be diagnosed. Management is IV blocker, control blood pressure immediately. Type A surgical intervention. Type B blood pressure is elevated. Chest pain, if chest pain is moderate, is cautiously. And the pericarditis, chest pain, with the pericardial rub also. ECG changes should be widespread. ECG changes in the lower valve. ECG changes is the diagnosis of pericarditis. Also, history of reverse some phase of pericarditis. It is the also, you see lots of patients in pulmonary embolism like of MI. So, diagnosis of pulmonary embolism is high degree of PSS because the diagnosis should be done is the disease exclusion. Sharp chest pain, dyspnea, cough, tachycardia, syncope is the some clinical presentation. So, chest without infraction, the chest is normal, or diminished pulmonary vascular the embolized area may be noted. And with infection, X-ray frequently shows peripheral infiltrated lesion, inflammation of the diaphragm, and pleural fluid on the affected site. So, chest is normal if without infection. So, if infection, then you finding some lesions. If you diagnose the pulmonary embolism, suspected pulmonary embolism, there is ascending dyspnea, chest pain, or sustained hypotension. Yes, cause because Pachona patient dyspnea, chest pain, ECG sounding normal, so we should suspect the pulmonary embolism. Clinical probability assessment, if patient is hemolytic stable, is so you do the DDMA may normal or elevated. If high clinical probability is CT scan can be done. CT scan is sometimes correlation from the diagnosis of pulmonary embolism. If patient is hemolytic unstable, so if patient is critically not critically ill, then you do CT-MRI. But if it is critically ill, do the transfusion and you show the right ventricular dysfunction. Sometimes you do the thrombus also. So you will go for the management of thrombatics. Pneumothorax also sharp chest pain. You see there is a yard and ventricular patient is sometimes bula. Also there is line of the lung. So with the pneumothorax, also immediate damage of the yard, life-saving condition. This is a sometimes rare condition. It is the border syndrome. Early shows mediastinal peritoneal yard. Hours or day later, widening of the mediastinum. Elevation also showed the rupture. It is the border syndrome. You see there is a mediastinal and there is that you see there is a in the case of pain, severe pain. So you should start something in the patient, in the rash, in the dermatome. Muscular pain is also disease of exclusion. Consider the young patients, low risk group, usually some triggering factor playing also some traumatic pain should be reversible. Analysis may be relevant. Is it is heartburn or my heart doctor? There is angina dyspepsia. It is common. Sometimes angina is the heartburn is also our heart attack, heart disease. So we should differentiate the angina dyspepsia. Angina is dull pain. Dyspepsia is a burning pain. Angina is by exertion, dyspnea, wash to mill. This is angina, but dyspnea better with the antacid or burping. In addition to the shock, it is in addition to back And Indian industry, the shortness of breath, this involvement, no shortness of breath, you should know. When to discharge or not to discharge, that is the question, because it is the most important for the chest pain. It is the emergency condition. So decision to discharge the patient with chest pain, the primary pain should be only after careful condition of the potential consumer, because a life-threatening condition sometimes you can miss in case of admission. We should, in Western world, search the cost analysis, because if a patient admitted to the hospital, there is a cost burden to the patient really. So you should meticulously in the OPD, you should diagnose the patient is the cardiac or non-cardiac questions. You refer that in the medical any discipline. But if you admit in the hospital with the enoxaparin and everything, there is some cost burden for the patient, also some life-threatening condition. Patient should be complex. That is sometimes miss the MI also, because it mistakenly discharged from the emergency, because some chest pain is not typical type of angina. So in case of AIDS patient, we should be meticulously, diabetic patient, meticulously risk factor more than 2 or 3 factors, you should search for MI also. But if not MI, why should I admit the patient? If not MI, remember that there are other reasons to consider the patient to have chest pain. One must have clear artery diagnosis with benign nature. So if it is benign nature, you can discharge the patient. But if it is any suspicion of pulmonary embolism, pneumothorax, you should admit the patient to the chest X-ray patient. Remember that diabetes and elderly patient prone to silent ischemia. So I should always consider the patient age, also gender of the in respect to the patients. It is the most important, because some real factor is in the nowadays in Bangladesh is improving the social media, also Facebook or any smartphone, everybody. So you should be safe. You should record everything when you examine the patient. Sometimes you give the antacid, everything. Patient on the way, the patient died due to heart attack. So sometimes it is solely doctors and nurses can be involved in this is mistaken. So you should cautious about the diagnosis meticulously. So patient should do the ECG, and ECG compared to the old one ECG, repeat ECG, do the X-ray, transfer echo, biomarkers, if it is ultrasound terms. So you should meticulously examine the patient and talk with the patient. History is the most important. How safety can be improved. Proper ties of the patient when chest pain. You should ties the patients. I can chest pain units and clinics. It is developed in a hospital, because in chest pain unit, good history taking skill, protocol and algorithm should be in the OPD or emergency department. Or use of sensitive marker in the emergency, because if it is take half an hour, within an hour, 1 hour, you put the top in eye and CKMB, so we can easily diagnose the MI or other disease. Also, in case of DDM, also do the diagnosis of the embolism. So conclusion, chest pain is one of the most frequently encountered complaint in both inpatient and outpatient settings. It is a significant financial burden on our healthcare system. Clinician must be able to rapidly and accurately assess a patient with chest pain to maximize patient outcomes and minimize unnecessary outcome. The evaluation of chest pain requires good history, and physical exam skill, ECG, X-ray, and few other diagnostic tests. So we cannot miss your. Thank you, everybody. Sorry, because I'm busy in the cath lab. After next time when do the roster, you should search for the cath lab schedule, because I'm engaged in the cath lab for after cath lab taking the class in the time. It is the time of taking the lunch. Also, you can go to some changing of the duty rosters. Students go to the evening duty. So lots of the students miss the classes. I don't know why I'm not hearing your voice also. So I think you take care of yourself. Stay safe. Corona is increasing. I think stay safe and thank you. Best is everybody. Assalamu alaikum. Allah Hafiz.